Thanks very much. Can everybody hear me? Is it okay? Lovely, thank you. I'm actually an infectious disease and public health physician by background, so all this science goes straight past me, so apologies if I don't talk to it. I know my limitations, just about. What I'd like to do over the next 5 minutes, if I may, is just talk to some of the health challenges, both from a Ministry of Health point of view, but also from a healthcare provision point of view. So I'll go on to the first slide, if I may. And what I'd like to do is just talk about the challenges. Now, I've got slides here which from the United Kingdom, but I suspect that many of them will be familiar to yourselves. So in the UK at the moment, on that left-hand slide, that shows the increase in life expectancy every year for the last, 2015 is the last recorded data. What's really interesting is that for the last 70, 80, 100 years, we've seen progressive increases in life expectancy. We're now seeing in the UK now that decreasing. And that's actually the first time in recorded history this has actually happened. That actually is a worrying trend, and that's only come to light in the last year or two. And the reasons behind that are several, but importantly is this increasing burden of non-communicable disease. Now, you could go here, you could go to the WHO meeting, and everyone will talk about non-communicable disease, either in the case of lower and middle income countries as a double burden, or in the case of industrialized countries as an increasing burden. It's not only an increasing burden on the health services, and that top slide on the right there, you'll notice I've used BBC News just to show you that I haven't made these up. So diabetes drugs are now costing the National Health Service in the UK over £1 billion a year. That's a huge, it's nearly 1% of all expenditure on diabetes drugs. And that's risen from about £300 million about 10 years ago. So we're seeing dramatic increases in costs, declining outcomes. And what's perhaps, from my perspective, is really most concerning is the bottom image there. Child obesity rates on the rise. Now, for many years, we've assumed that the medical science, the medical innovations will deliver the silver bullet to non-communicable disease. What's clear is that we're going to have to do something much more radical and much sooner. Child obesity rates in the United Kingdom now are up to 20% in some of the poorest urban areas. Now, I make that point because what this means is that these children, if we don't do something for them now, have a really bleak prospect to look forward to in adulthood. Because this childhood obesity, a combination of poor health outcomes, poor social outcomes, poor outcomes across environmental outcomes, is almost a toxic sort of triad as far as these are concerned. So the next slide, if I may, Chris. So we talked about one of the things that we have done over the last probably 30 to 40 years is that most of our interventions around non-communicable disease have focused around one or two things. The first thing is about changing behaviour. Now, those of you in the room who've tried to change your own behaviour, and I'm sure all of us can occasionally have done that, will realise how difficult it is. Trying to change behaviour at scale is exceedingly difficult. And the evidence that behaviour change, the ability to achieve behaviour change at scale, is very limited. And it's particularly limited in industrialised countries where the focus is on individuals and individual responsibility. And the reason, well, there are many reasons behind that, and most of them are political. Moving on from the behaviour change model, which I would suggest that has significant limitations, and we haven't been able to manufacture behaviour change at scale, except when we've used legislation. So seatbelts, smoking are good examples when legislation has been really important in driving behaviour change. But the environment, we've been using environmental modification for human health outcomes since, well, for millennia. Those of you who remember back to Hippocrates on airs and waters, etc., he articulated beautifully exactly what we needed to do. Now, the reason I put up these references here is not because we've got Christine in the room or things like that, but to demonstrate that we, in the last sort of 5 to 10 years, as my colleagues have said, there's been a dramatic expansion in our knowledge base. And I'm going to suggest to you that actually Craig's work that he spoke about a minute ago takes us into a subtly different realm of discussion. Whereas we heard Chris Lees talk about policy. What I'm interested in is how we start to translate policy into practice, and we start to influence practice in the healthcare system. Now, I don't know how many of you work in the healthcare system in here, but most of you who do will be very acutely aware of the pressures on hospital beds, on healthcare services, and the increasing numbers of people seeking care. What Craig touched on there was how this work that we and you are involved in has the potential to reduce demand on the healthcare system. Now that's really important if you're a healthcare policy person or a healthcare administrator. So I'm suggesting that we're now entering a realm where science can actually start to provide solutions for the healthcare system, not just for what I would call the public health system. So I'd like to just finish with 1.5 slides and just illustrate to you how the language is changing in the United Kingdom now. These are 2 documents, they're both from the King's Fund, but they represent changes in the United Kingdom policy and practice regarding the healthcare system. Now, the one on the left, you'll see, talks about going beyond integrated care. I don't know how many in the room are familiar with this shift from health services to integrated care services. It started in America probably quite some years ago now. It was taken up in Australasia. It's now being taken up widely in Europe. Some would argue, the cynical amongst us would argue this is an attempt by healthcare to displace its cost to other parts of the public sector. I couldn't possibly comment. However, from an individual point of view, it makes no sense, either from a planning or a delivery perspective, to separate out healthcare provision from the provision of other essential services to the public. So interestingly, the United Kingdom government are now talking about, wait for it, sustainability and transformation plans for health. So they divided the country into 1 million population segments, and each of them have had to draw up sustainability and transformation plans for health. Now, I've been around in health a long time, and I've never heard the healthcare sector talk about sustainability and transformation. So I'm saying this because I think there's a huge opportunity here. The language is changing, and as the language changes, so we can influence the discourse. And that in itself is really important. The other word, though, that's on that left-hand document is systems. Systems word is now becoming, and systems thinking and how we construct our systems is going to be really important. So we're no longer talking about just organizations. The shift has been to people and place. So for the first time in the United Kingdom, they're talking about healthcare around people and place, not around hospitals and doctors, etc. That's a fairly fundamental shift, and that in itself provides a huge opportunity. Now, in 2 weeks' time, the NHS is about to publish, National Health Service, in the United Kingdom, is about to publish a 10-year plan. And I'd like to just highlight 2 other opportunities that are going to present in this. The first one is it's going to have a focus on the life course. Now, the reason why that's important is partly because of intergenerational effects, and to stop us thinking about diseases just as they accrue to certain parts of the community. But it offers us an opportunity to think about what things we can do across the life course that might actually impact, if we go back to our children's example, the things we can do that have a pervasive effect for all parts of the life course and all parts of the community. The other cross-cutting theme in this new 10-year plan is going to be about inequalities. And so I can go on to the last slide if I may, Chris. And it's the inequalities thing I'd just like to finish off with. Because I think we're at a place now where there's a tremendous opportunity to bring issues of environmental justice, social justice, and health justice together as one issue. And this sort of language, when the health sector starts talking like this, then it's, in my view, time for all the other sectors to start to say, we can help you with this. And by the way, you can help us because you've actually got all the money in the main. Sorry to be so cynical about that. So I think the time is now. And I think, you know, the science is evolving. We'll never have enough science. There's no such thing as perfect evidence. But there's no reason, on the evidence we have in front of us, not to proceed, to do things differently. So at that point I'll finish because I'm way out of my depth on the science. But I do believe that at least that's an illustration, I hope, of an almost unique sort of opportunity for us to have a different discourse with the health sector and the healthcare providers. So thank you. Oh, yeah, we've got time for a couple of questions if anyone wants to explore that. Or I'm happy to talk afterwards about it. Okay.
Thank you, everyone.
Thank you for your talk. It's very interesting. I just wondering, you said 20% of the children have obesity. How many of them is inherited and how many belong to the behavior? And could we use microbiome for curing the inheritance disease if they have a defect in their genetic background? Could microbiome can be a solution for them?
Wow, yes, that's told you I didn't know much science. So you I think it's interesting, that question, isn't it, of how much is inherited. Well, what's interesting about that 20% is that birth weights have been creeping up. I take your point, and there is much more gestational diabetes, so we're seeing bigger babies born, etc. But what you do see in that group is rapid increases in weight from about the age of about 3 or 4. So you see children relatively in their early years starting to sort of grow normal, and then their weight as they start to adopt tradition, and all sorts of things happen, don't they? But that weight increase, it increases up to about the age of 11 or 12 and then goes on from there. So I think you're right. I think we need to explore all sorts of possibilities, how the microbiome might influence it. But yes, I would actually defer to my colleagues who probably know more about these things than I on this one.
Dave, I can actually follow up on that a little bit.
Oh, great.
It's a really good point, and there are intergenerational effects on things, especially like obesity and diabetes. And there is evidence now that some of that has to do with the human microbiome. So our gut microbiome has been associated with obesity now. And we are not at a stage where we can cure obesity with the microbiome. But there's a lot of work in the medical profession right now going on to address exactly that question. And that's where people are looking in the future. Yeah, really good point.
Em, there was a question over there first. Thank you.
I'm Karin Zaunberger from the European Delegation of the European Union. First of all, thank you very much for this very, very interesting presentation. For me, this is yet another strong, convincing argument to increase the green spaces in the cities. So one comment I should make when you say HUMI in 20 countries by 2020, I really think be more ambitious and perhaps, join forces, because greening in the cities is also for climate change adaptation, mitigation. Maybe we can pull forces together and be part of this action agenda that has been launched just a few days ago from Sharm el-Sheikh to Beijing. I think this would be, health is something really, this touches us all, and so I think this is hyper important. Now I have my question, because when you showed how the microbes are everywhere, actually we are like an ecosystem of microbes. It's also quite scary. I think for most people it will be hugely scary. I think because microbes are usually seen as something negative. You have to wipe it out. You have tons of, really plenty of stuff to, we do everything not to have microbes. It needs to be completely clean. I think that's what a lot of advertising tells you. So I think for the person in the street, I include myself here, so many microbes, just to make sure that they're all good to me. I think that is maybe something you will have to overcome, to make sure that there are goodies and baddies. We know the goodies in the yogurt, think that people know, but generally speaking, microbes are really perceived as the monsters, the mini monsters I don't see. And yet you see, well, they do so much good for us, and I think hopefully there will be a lot more green space, I mean, also for climate change adaptation, mitigation, disaster risk reduction, all these reasons. But I think we should try to pull all on one string and not have only 20 countries, have 200 or maybe 2,000 cities. If you don't specify the size of the city, I think all these cities have to gear up for adaptation. I mean, if in the back of their mind and on top of it, you do something very positive for your population in terms of health, I mean, what are we waiting for? Yesterday was the time. Thank you.
So thank you, and I think that's wonderfully evocative. And you've issued the challenge very carefully, and we would love to respond to that with you. The issues that you raised, some of my colleagues are better able to talk to that than I am. But they're debating who knows more. Oh, right.
Answer for a second.
I think you're exactly right. It's overcoming the mindset of the traditional microbiology that the only good bacterium is a dead bacterium. You sort of need to move past that. The new science is saying that the vast majority of bacteria, for example, are not pathogenic. Some of them beneficial, some of them may have no role. We're sort of still finding that out. And bacteria play at least 3 critical roles. They from the environment. They help colonise our protective bacteria. They play an active role in immune signalling that can sort of trigger defence mechanisms or also tolerate things. And then thirdly, they help build immune memory. So the microbes from the environment help play these critical roles in our health.
Thank you very much. I just want to add to my colleague from the EU. If you want to maximize the impact of your initiatives, you might need to consider joining forces with other existing initiatives like the WHO Healthy Cities initiatives. They have some on green space in it, but not to this detail on microbiome and others. There are other also initiatives for healthy environment under the climate change adaptation work. So if you consider those two and maybe biodiversity as well, so you have all the forces together to have maximum